Hello, welcome to our first IDSOG Ask the Expert series. I'm Sarah Daughters-Katz, and I'm here today with Dr. Carolyn Mitchell. Dr. Mitchell is the director of the Vulvovaginal Disorders Clinic at Mass General Hospital, and as such, we can easily say that she has an interest and really an expertise in vaginitis. But I won't steal her thunder. Let her introduce herself.
Thanks, Sarah. I'm so pleased to be here, talk about one of my favorite topics. So I am a generalist, but I spend 80% of my time in the lab studying vaginal bacteria and mucosal immunology. And so I think about this literally all the time.
We are so excited to have you. Today, we're going to get the inside scoop on vaginitis, specifically bacterial vaginosis, and we're going to review a recent article by Munzi et al. Entitled The Narrative Review of Current Challenges in the Diagnosis and Management of Bacterial Vaginosis. This article is a review article, but the authors do a great job of comparing all the treatment options for BV that are out there. As someone who's not really a BV person, we sort of know there's Flagyl and Clinda, and you can do them orally or vaginally, but they really do a really, I think, thorough job of explaining all the different formulations and also then comparing them. They also talk about some of the challenges in managing recurrent BV, which I think is a common clinical conundrum that many of us face. For me, I thought the review of the treatment options was really, really helpful in kind of expanding what I understood about BV, especially the alternative options. And if you want high yield, when you look at the paper, table 2 is where it's at. But I'll be really interested to hear kind of more on Dr. Mitchell's thoughts. The discussion about biofilm I thought was fascinating. And when you think about BV potentially as sort of a sinister or nefarious player in preterm birth, in PPROM, in STD acquisition, kind of how that all puts together. So let's ask our expert, Dr. Mitchell, what do you think is important? What did you take away from this paper?
So I think I took away a couple things. One is that no matter which treatment regimen you were looking at, the success at 1 month, which the FDA asks people to look now, they ask them to look at like 7 to 12 days, 9 to 12 days. But most of our patients care like, so I get better for a little while, but then it comes back in a month. So cure at a month is really, I think, what a lot of patients care about. And if you look at that, no matter what the treatment regimen, it's like 60 to 70% or worse. Which is why for everyone, I mean, I think many people look on their schedule like, oh, vaginitis. Why am I seeing a patient with vaginitis? And that's why, is because our treatments are bad. And I think that's sort of one of the main things is no matter what you pick, there are some nuances and you can pick some better things or some not, but we don't have a really great treatment. The other thing I'll say is that table 1 looks at the diagnostics, and I think what it shows is that for many years people have used this BD Affirm, which looks just for Gardnerella. And if we know one thing about BV, it's that it's not just Gardnerella, that it's a mix of things. And so most of the other panels of tests that are out there look for multiple different bacteria and use the conglomerate to decide about a diagnosis of BV. And if you don't have a microscope in your office, which most people don't anymore, using one of those tests with multiple bacteria is going to give you a better sensitivity and specificity than a test that looks just for one bacterium.
Ooh, that is really good to know. We're old school, we still have a microscope, but it's helpful to know what you can do if you don't have a microscope for sure. So I'm curious, as someone who thinks a lot about this and reviewing this article, what did you feel like was sort of the strength of this article? What did it kind of really bring out well?
So I'll say actually, so Dr. Musny is a IDSOG member, and it was another IDSOG member, Dr. Sobel, who told me about this article, and I agree with his assessment, which is this is such a good review of what studies have been done, the sort of, at different times we define things differently. So like comparing apples to apples is often very hard to do in this field. And so I think the paper did a really excellent job of trying to compare apples to apples and give some assessment of the relative benefits and drawbacks to individual treatment regimens. I also think in a relatively short paper, for those of you who are wondering how much you have to read, it's a relatively short paper. They did a very nice job covering sort of the breadth of things we know a ton about, like metronidazole and clindamycin, to things that are very new, like astrodrimer gel and boric acid.
Yeah, I actually really agree. As someone that works a lot with medical students and with residents, I think this is a really nice digestible review paper that hits all the highlights, hits all some of the kind of nuances for people who aren't vaginitis experts, but in a really digestible way.
Agreed.
Anything you felt like was sort of missing from this paper, or kind of areas where they didn't quite, wasn't quite as robust as others?
I think first, our lack of understanding about the cause of BV is a weakness of the field, not this paper. And so it's really hard to know how to treat recurrence and talk about prevention when you don't know what the cause is. Like, it's a very challenging. And so the paper talks about, it seems like it's sexually transmitted for some people, but we don't really know. We haven't found the agent. So that's a weakness in the field in general, and I think limits our ability to do good preventive interventions. The other thing, I think this paper came out right before the Lactin V randomized trial of a vaginal live biotherapeutic product. So the probiotic paragraph is one paragraph. There's tons of studies. They're reasonably poor, but I think there are some nuances there. There are also tons of reviews about probiotics, so I understand why they didn't focus on that. And I think that was a good choice.
You mentioned a little bit about, because we don't know the cause, we can treat a symptom, but we can't really treat the etiology. I feel like I'm in the obstetric world because we say that all the time, but it's nice to know that other fields have that issue as well. Are there other parts of kind of the BV story that you feel like are important for sort of non-BV experts to really kind of understand that we often just miss?
I do think this question of, is this an STD or not, is a really open, controversial, and interesting question. And I think the epidemiology, it follows right along with many of the other STDs. You'll see plenty of patients who say, I was fine until this particular partner. And with this person, I always have recurrent BV. And then I broke up with that person, and now I don't have BV anymore. And that seems very consistent with a sexually transmitted something. However, we haven't been able to find the thing. Like, there's not a Koch's postulate. And there are plenty of people who go on to have recurrent BV even without a partner at all. I do think there's been a treatment trial, a pilot in Australia, where they used topical clindamycin on the penis as well as oral flagyl for the male partner. There was a treatment trial in the US that I think was stopped early, so we may or may not have information about treating partners, but having a consistent partner is a risk factor for recurrent BV, and if you have a female partner, having a female partner with symptoms is a risk factor. And we really haven't included partners in many studies because it's hard to do. It's incredibly hard to do, but that's sort of the missing, because if it is an STD, then we're missing the whole, like, what we say for every other STD, which is treat the partner. But because we haven't been able to find an agent, we don't currently do that. So I think that's just one of the big, open questions for the field.
And then to get back at my question, what are your thoughts on sort of this biofilm hypothesis and how that plays into the whole story?
So the biofilm paper that sort of brought this up is by a guy named Dr. Swidzinski, and he has this beautiful immunofluorescent vision of the biofilm on the vagina, and it's probably like 20 patients. And the people with BV who were studied were people with highly recurrent BV. And BV is a syndrome. So I think for some people, there probably is a biofilm. And in many cases, that is part of the problem with recurrence. Do I think that's true in everyone with BV? I'm not sure, and maybe not. I also, boric acid theoretically was going to be the thing to disrupt the biofilm. Does not have better efficacy than antibiotics, at least in the one clinical trial of 2 formulations of boric acid, did not have a placebo group. Again, about 60% efficacy, like about the same, which some people might say, sweet, I don't have to take antibiotics and I can use this thing. Great. It is a poison, just to say there is that. And then there have been a couple other potentially like biofilm busting products that have been tried in the lab that have not, as far as I know, made it into the clinic yet. So without a model system to check how important the biofilm is, I think it's really hard to say.
So if the NIH was like, Dr. Mitchell, we're going to give you unlimited funds to answer one question in this field, we're going to grant your R. What's your question that needs to get answered?
So it would be the RO one that I just put in and didn't get funded, which is for vaginal microbiome transplant.
Ooh.
Because I think an interventional study is how you move things forward. You find out if we push here, what changes, and then we know like what levers are moving and how the gears work a little bit. And probiotics mean you have to pick a thing, and like I'm not sure we know enough how to pick the thing. Although again, the Lactin V trial suggested that they picked a good thing in that trial. But I think vaginal microbiome transplant, although not sustainable and likely not a long-term intervention, you put the whole thing in and see, does the whole community provide benefit in some way? What are the things that seem to stick around and are associated with good outcomes? What things might be associated with worse outcomes? How much is the host? How much is the microbiome? To me, it's sort of the, it takes the lid off and you can look at the gears underneath, because I don't think we even know what the gears are.
What a cool project. Well, I'm sorry your art didn't get funded, but it seems really interesting. So we're sort of nearing the end of our discussion. I think for all of our listeners, give us 1 or 2 kind of take-home points. Like if you learned anything about BV from this article, from our conversation, like what are a couple big things for people to really understand to help them take better care of their patients?
Yeah. So I think the number one thing about vaginitis in general and BV specifically is you cannot diagnose it over the phone. And that is said in this article as well. So like, and if you're relying on a test like the BD Affirm that looks at one bacterium and that test is over and over positive and your antibiotics aren't working, it's probably not BV. It's Gardnerella, which is different. And so I think being very, you have to examine people with vaginitis and ideally use a very specific test if you can, to be sure you know what you're treating, A. B, finding a treatment that works for the patient is important, and they're all about the same and none of them are that good. So ideally you want something that the patient will be able to take to have the best chance of success. And then 3, probiotics right now, it's such a nice idea. Most of them are not worth the money, in part because they're regulated as dietary supplements. And what's on the label may or may not be what's actually in the capsules. And it's why trials of things that will be called a live biotherapeutic intervention will be regulated by the FDA, be upheld, quality standards will be upheld. Those, I think, will be the next phase of what we're using.
So many interesting things to think about, just beyond kind of what I think about on a daily basis. Thank you so much. We appreciate your thoughts and your expertise. And thank you to all of our listeners. We're super excited to sort of pilot this series. Stay tuned for our next IDSOG Ask the Expert series for another big player in the vaginitis world, vulvocandidiasis. We'll see you there.
Shout out to our IDSOG member, Dr. Musney, whose paper this is.
Great article.